practical session.
Into a refractive cataract surgery. If you do a very good, excellent cataract surgery and a patient has to use a -1 error, your cataract surgery is labeled as a failure. So the patients demand spectacle-free life, and with the advent of premium IOLs and robotic surgeries, it is becomes a very challenging situation. So we all know that approximately 1 mm of axial length error can give rise to 3 diopter error of refraction and in a normal eye, and 1 diopter of keratometry error would lead to 1 diopter of IOL error. So this has been the biometry journey so far. We started with the ultrasound based machines, and now we have the optical biometers which are slowly improving with time. So coming to the ultrasound based biometers, these were based on the piezoelectric crystal that emits and receives high frequency sound waves, and basically divided into 2, the contact and the non-contact method. The contact method, it had various issues of like corneal compression, fluid excess, misalignment of sound beam, inappropriate eye type, it can lead to errors, and there is minimal risk of microbial inoculation. This is how it is done. The patient is asked to look straight in the red beam in the probe. Coming to the next, immersion scan. So this has been the gold standard for a longest time now, and it minimizes technician variables and gives better results. So the patient is asked to lie down on the table, and this is how it is done. We have to carefully look for good spikes and adjust gain accordingly. So I'll just be playing a short video. So water is injected in the cup, and again the patient is asked to look straight. We just have to ensure that the spikes are good and the gain is appropriate. So there are special cases in which even this can lead to erroneous results. So we did for a patient, we did both immersion and lens star, and you can see that the IOL power is absolutely the same. So if you are having a solo practice, immersion A scan is very good, and it is still valid to be used. With the companies bombarding you to take this biometer, that biometer, which are very, very expensive, A scan still holds good. So special patients like low vision, nystagmus, blepharospasm, they can be a problem. Patients with posterior staphyloma, macular lesion, vitreous lesions, in these patients we have to add on B scan, do a B scan along with A scan to give accurate power. Then in dense cataracts we have to increase the gain. And as we all know, silicon oil, aphakia and pseudophakia, we have to adjust according to the velocity of the sound. So pseudophakia, again, we have this formula to calculate, and then we adjust. Post-refractive surgery, in these cases, I would suggest that we should go for an optical biometer, because this presumes that the cornea is spherical in shape, and we all know that posterior cornea is 1.32 diopters steeper than the anterior, which is further altered post-refractive surgery. Although we have been having various formulae to derive the IOL power, but still the optical biometers are preferred for these subset of patients. Now coming to the advantages of optical biometers and what are the current biometers which are available. So it measures the axial length from the vertex to the photoreceptor instead of ILM. Also, the optical biometry calculates optical axis instead of anatomical axis, which is more accurate. And the accuracy is more for optical, which is 0.12 millimeter. In pseudophakic, phakic IOLs, it is more accurate, and kind of IOL material basically doesn't, it has no relation with it has less impact on the measurement. In myopic eyes, staphyloma, silicon oil filled eyes, there is no need to convert or use any formulas. So these are the stack of options which are available with us. And there is a detail. It's a very short time for me to kind of go into each and every one. But yes, I've divided these optical biometers into 3 main parts based on the principle which they use. First of all, we had partial coherence interferometry-based biometers, and Zeiss's IOL Master 500 is the prototype of the same. It uses an infrared beam, and it is taken from tear film and photoreceptor, and it uses laser interferometry to calculate the axial length. Just a second. So you can see this is the scan. It calculates one-zone keratometry and wide-to-wide diameter as well. Coming to the next one, which is the Lenstar 900. It is again based on laser interferometry, and it permits full A scan of the entire eye, and also it can take up retinal thickness as well. So you can see this printout. This is the measurement which it takes from the corneal surface, CCT, and you can even calculate retinal thickness with the same. Other OCI biometers can also, they have topographies incorporated like Aladdin and Galilei. So the key features are, the Lenstar will only measure when the patient fixates, and it is measured within 30 to 40 seconds. It improves the quality of data, and the measurement is axial. Its reliability is very good, and the chances of errors are very minimalized. So this is a printout of all the measurement which comes with Lenstar. This can also be used, and in fact we use it for ICL measurements and LASIK screening and all. So this is the IOL printout. It has all the newer generation formulas like Barrett's and Oslin incorporated in it, which are excellent for post-refractive surgery, RK, keratoconus patients, etc. We can also see ankle kappa for calculating post for multifocal patients. It has a Zuel Done excellent keratometry, which measures almost 32 points. The only two disadvantages which are there with Lenstar 900 and IOL Master 500 are that they cannot be, they cannot be done for used for a very dense cataract and hazy media. So almost for 30 to 40%, again we have to resort to immersion A scan. Also, they lack the reading of total keratometry. So this is taken care of now by Zeiss's IOL Master 700. It is based on the swept source OCT technology, and it takes almost 2,000 scans per second. Others are Tomy 2000 and iStar 900, which are also based on the swept source technology. In this, you actually see what you measure. So the chances of errors are least. It has 3-zone keratometry, wide to wide, and you can actually check the fixation. In unusual eye geometries, like we can see if there is a tilted lens, and there are fewer refractive surprises because we can actually observe the foveal pit while taking the scan. So this is the eye. You can see a good foveal pit means the scan is correct. There's no foveal pit, so the scan is not correct, and which can actually lead to errors. Like in this case, there's almost a difference of 1 diopter difference in the IOL power. So now coming to another, we can also see if there is any retinal pathology to be in the patient of cataract surgery, which is very, very important. Sometimes we just miss, due to hazy media. So there are very few refractive surprises. You actually see what you measure, and the reliability is very high. And most importantly, it can be done in very dense cataracts. Almost 90%, in fact 95% of cataract patients now we can actually do a IOL Master 700. So, and it just takes less than 40 seconds to be acquired. Just ask the patient, and you are done. To look in the light, and you are done. See, it's done. The repeatability is excellent, which has never been there for any prior biometers.
Deepa, you'll have to sum up.
Yeah,
please.
just the last few slides. So, and another very important topic that I would like to just touch up is the availability of total keratometry, which also incorporates the posterior curvature of cornea, which is there in this particular machine. And it also has Barrett's TK, which is customized for the same. So basically, for for the patients who have abnormal corneas like post-refractive surgery, post-RK surgeries, and high myopic eyes, these newer generation formulas are excellent. Same is with the toric. So just wanted to touch up this one practical tip for the toric. So the people who don't have a true K, you just have to remember that if a patient has a withdrawal astigmatism and vertical meridian is steep and plus cylinder is at 90 degrees, TK would be lesser. So if the patient is having like 0.75 or 0.9 cylinder, you might not go for a toric. And similarly the other way around. So this is how the toric calculator was there. Again, angle kappa can be measured. And further, we now have aphakic refractive measurement like on-table biometries, which is being developed. So to summarize, biometry in its current stage is most accurate and turned cataract surgery into a refractive surgery. Immersion scan still works best for most of the cases, more than 90 degrees. And calculating accurate corneal power and proper acquisition of the scan has no substitute. And the latest biometers like IL Master have newer software to handle these cataracts and special situations. Thank you.
Thank you, Dr. Deepa, for a very extensive talk. I just wanted to highlight the one important message which was there in the last slide, that a lot of times when we are starting our practice, it is very difficult to buy these expensive optical biometers. So what Dr. Deepa very clearly mentioned, that 90% of the time with immersion you are going to be right. So don't think that if you don't have an optical biometer, you can't do a very good cataract practice. Till last 2 years back, I was doing all kind of lenses with immersion. So you have to be very, very confident with your immersion. Take a couple of readings for your keratometry so that you are bang on. And in case if you are in doubt or you have a very demanding patient, maybe you can send your patient if you don't have the optical biometer. Yes, optical biometer is the ideal, but you can still have a very good practice with immersion. This is what I wanted to highlight. And with the newer biometers coming in optical, I think we have a lot of advantages of, when I want to add something.
Yeah, I would like to add, I think the most important part of the presentation was that optical biometry is not a must. Immersion works almost as well, and that's the gold standard. So don't be hesitant of using premium IOLs, which Parul is going to be talking about in the next presentation. If you want to put premium IOLs, make sure your biometry is good. You may do it yourself if you want to, train your person to do it well. And most important thing, don't promise them perfect results. I think that is one thing that we always get carried away. The results are very good, but still the things can go wrong. Always be aware about refractive surprises. So always be careful about what you promise. And I'm sure Parul will be talking about that as well in the presentation. Yeah. So next, Dr. Parul will be presenting about incorporating the premium IOLs into our practice. Anyone has any questions with this talk, we can just take one or two, or otherwise we'll just... And again, we would like that you people can interrupt the presentations anytime if there is some questions. So we want it to be more interactive rather than just a one-way didactic lecture.
The most important is that time for contact immersion is gone. So if you are practicing in contact, at least you have to shift to immersion. That was the entire point of the topic. If you are not having optical, doesn't matter, but at least you should have immersion in 2024. No contacts.
So